about temperature management? This thing, okay, I can just like leave this on the back of my four-wheeler and take it all around. It's good, right?
Yeah, it's fine.
Middle of summer to
Do
the
whatever you want.
middle of winter.
Yeah. These boxes really like cold temperatures. So you want to keep the drugs, generally speaking, 68, 78, somewhere in that range.
Fahrenheit.
Specific drugs.
I'll be a nerd. Fahrenheit.
Yeah, Fahrenheit.
F.
Yep. You can do the Celsius conversion, but
I cannot.
for most of the drugs, now each drug might have a little bit of a variance there, but that's the general. So, yeah, if you are storing these in an ambulance that is going to be outside overnight, most times of the year that's not going to work. It's going to get too warm, too cold. And the biggest thing is a lot of these medications, they will degrade if they're outside of those. You start freezing some of these drugs, they're not going to work anymore. When they become more potent, you don't know. It's kind of a crapshoot. But you want to make sure you keeping the temperatures within the range. You should have a way to monitor that as well. So that's something in the hospital we monitor multiple times a day. We have continuous monitoring. And those alerts go to my phone all times of night. If something goes out of range, somebody leaves a freezer open, I get alerted.
You get in there, right?
Yeah, it's great.
Speaking of alarm fatigue.
Yeah. So, but yeah, you should have some way to monitor that to make sure that those temperatures are staying in that range.
What about wasting of medications? What is proper wasting technique? Is it in the gravel on the side of the road? Is that acceptable, or what does proper destruction look like?
Yeah, so Board of Pharmacy, Ohio Board of Pharmacy, I think it's probably true across the board. Yeah, you must render it irretrievable. So this does not include in a sharps container because you can
dump it out.
Get that back out. The best way to do this is I'm going to throw out RX Destroyer as a brand name, but there are other types where it's a jug of activated charcoal that will render it irretrievable as approved by boards of pharmacy. Other options, kitty litter is coffee grounds, something that will prevent somebody with bad intention or kids from getting access to that medication.
It's a potent coffee you just made.
Yeah, right. The idea with the coffee grounds, they're very super bitter, right? Sure. And so, not going to swallow. But down a drain, not environmentally friendly, but still meets that requirement. You can't get it back. So, you kind of have to do the best with what you can, depending on the situation. But that is the ultimate. If you can render it irretrievable, you're covered there.
The one thing I want to add on to security, though, is one of the things that probably most people don't think about necessarily are summer months right now that we're recording this. Bay doors are open, ambulances are unlocked, doors are open. You have to make sure that your drug boxes are locked and secured. You're probably violating pharmacy board recs if you can get direct access to your drug box in that situation. So something to just be aware of if you're sitting outside in front of the ambulance, it's one thing. Doors are open, no one's around. You can just walk in there, grab a drug box.
So
I've been known to drive by to look to see if there's free access to drug boxes, just to make sure that my squads are locking up their stuff.
So there's one fire station in Portage County. They have I don't want to call it an alarm, but it rings a bell. So if their bay doors are all open, there's a sensor.
Yep.
If you break the sensor, it rings a bell that tells you somebody just walked into your bay, right? Because a bunch of our fire stations, including ours, is very broken up, right? We're 3 add-ons, 2 very big add-ons. So the ambulances are over here. You could be way over here. You have no clue someone walks in the bay. And yes, that's something we worked with pharmacy on. Someone should not be able to walk into your bay, open the door of the ambulance, and then just grab said box.
Yep.
It needs to be in a locked cabinet in your fire truck, in your ambulance, in your sprint unit, car, whatever. It needs to be secured. And there are also affordable ways to do that. Like we talked about off camera in your ambulance, even if you have the sliding the sliding doors, which is just normal to Braun. A bunch of different ambulance vendors have those types of doors. And if you're putting your drug box in there, there is literally like a $20, I would call it a jeweler case lock, that you can buy on Amazon. You can program the code so somebody could get in and they can't get into the cabinet, right? I mean, if they did destruction to your ambulance to break it, to steal the drug box, then that's a different story, and I think the DEA would fully understand, pharmacy would fully understand when the investigation is launched, and PD would, but you should not be able to open the door of your ambulance and just be like, I'm taking it, see ya, I'm out. That's where you get in trouble. Also for, like, ambulances that post. So if you are, maybe your company has posting positions, that's big when it gets to that. So that's why there are ways to secure your ambulance. You can spec an ambulance to lock all the doors, let it run. There's a hidden switch, obviously, that we all know about to make sure the ambulance is locked and secured. That meets sufficient Board of Pharmacy requirements. I can't open the door, I can't get to the drug box. But definitely good things to think about. But there are cheap solutions to secure your drugs in your ambulance, because I know over the years we've had some people like, well, does it have to be this? Does it have to be that? I mean, we've had even EMT providers purchase little like gun safes, for lack of a better word, that's bolted into the cabinet on the side of their rescue.
100%.
And they have to enter a code and it opens and there's the drug box. That's great. They would literally have to destroy that to get it out. So, I mean, the Board of Pharmacy is pretty reasonable.
That just strengthens his tamper evident
100%
part. Right? You walk in. If somebody wants it that bad, they're
they
going
can
to
steal
get it.
it.
I
Sure.
mean, there's going to be a boot print in the middle of the door, and you're like, something happened here, right?
Hulk smash.
Yeah, right.
Or like supervisor vehicles, chase vehicles, they're probably going to have a secondary drug box in the back.
Yep.
If they want to break that window, they can just break that window and grab the drug box. I mean, obviously destruction there. You can't, if they want to get it, they're going to get access to it. But we have to give a good faith effort to stop Gen Q Public or anyone else trying to get access to the drugs that are in your possession and your control.
So earlier, Derek, you mentioned third most common medication was Zofran, I think, as was what you cited. What are the other? Let's go to both ends of the spectrum here. What's in our area anyway? What's our most used and what's our least used?
Yeah, so things like Duonebs, Zofran, Tylenol, those are really commonly used meds. In a year, our area we use in the thousands of those meds. Compare that to EpiPens in the BLS boxes, much lower usage. Hydralazine, glucagon. I don't think hydralazine's even in our boxes, but glucagon is a much lower usage. Labetalol not used very often. When we think about from an
Pitocin. I'm sure we don't use a lot of Pitocin.
Right. Going to an error standpoint, when we do use those meds, we aren't as familiar with them.
Right.
And so that gives us a higher risk of error just from lack of usage. But yeah, those everything else kind of falls in. Almost nothing in this box. I mean, it's been pretty finely tuned. Almost nothing is never used.
Correct.
Tetracane's another one, not commonly used, but there is usage. So yeah, this has been worked on for years and years and finely tuned to make sure that we aren't wasting too much when it comes to expiration dates and never using a med.
Yeah, and having appropriate quantities
Right.
of the medications we're actually going to use that have the biggest impact. Right?
Yeah.
There's several in there. Single agent we might use for multiple indications.
Right.
When there are other medications that fit that same indication. Why carry three things when you can do it with one, right?
For sure. Each one of these boxes has just shy of $600. Each one of these boxes has just shy of $600 worth of medication in it. We have across the system 1,000, 1,100 boxes, somewhere in that range, that are out in the field right now. It's a lot of money that are in drugs. That's why we want to make sure that we have the right quantities and we're not wasting. So we can get some money back for some of the expired meds, but Not much.
Well, that's one of our biggest costs in EMS is not actually drug usage.
Right.
It's drug
It's
waste.
Yeah.
Right?
It's having it available.
Having it available.
Yeah,
right?
yeah.
And having those drugs that rarely use that are expensive and then expire out. I think the only other thing I think we should talk about with the drug boxes and talked about earlier with dosages in pediatric patients is difficult. And obviously when you throw in a high stress situation such as a pediatric cardiac arrest, we have a tool in our drug box to help us with dosing of those medications.
Right over your shoulder there, yeah.
Yep.
Yeah,
So
right over there.
we've talked about it before, but that's Certidose. So do you want to talk about Certidose?
Yeah. This is Certidose. This is a product that we actually worked with the company through pharmacy, had multiple calls with Rainbow. RBNC in Cleveland is our children's hospital for our viewers that are not in Ohio, but we worked with pediatric pharmacy, physicians at Rainbows, pediatric pharmacists at Rainbows, and got a lot of people involved. But the most stressful situation would be a pediatric cardiac arrest, right? We've all unfortunately been on those calls, and what we found in working with pharmacy, and shows how good of a team we are at UH, is we're really good at converting a pediatric patient from pounds to kilograms, right? It's pretty simple math. We can all do that. And then we're also really great at multiplying that. So,
Correct.
I know epi is 0.01 milligrams per kilogram, and I know amiodarone is 5 milligrams per kilogram. We're good at that. So I can take a number, multiply a number, and be like, yeah, I need to give 10 milligrams of amiodarone. And then I'm like, okay, I have to get the volume of 10 milligrams out of 150 milligrams in 3 mLs, right? So that's where our mistakes typically go. In pediatric meds, that's where usually our error is. We have the correct dosage. It's just how do I get that volume? So the protocol is one big plug. I want to give a plug for that. For our protocol is we have the pediatric tape, for lack of a better word, not trying to use a brand name or trade name, but going across
universally accepted as the
yes.
color coding of our
Yes.
Yeah.
That may look like multiple tapes, but going across the top, we have the tape with height, weight in pounds, weight in kilograms. You can touch that. It will take you to the medication chart, which will allow you to give you any drug in this drug box that weight child can handle, tell you not only the dose, but how many milliliters of volume you actually need to drop to achieve that dose. Please use that.
In our common concentrations.
Yes.
It's only at the concentrations we have in the box.
Correct. So I think
most
that's
commonly, because it might come out for shortages.
Sure.
So
Yes,
just to be aware of.
So when we're talking about med errors, the peds is like that's it, right?
Well,
we want to prevent that.
There's data out there that looking at pre-hospital pediatric arrest, upwards of 60% of administrations had errors of underdosing and overdosing. There was a study looking at it was with a pediatric resuscitation app was who put on the study, but in their simulation environment, it was greater than 60% error rate. So yeah, this is an area specifically that is so prone to error if you're not utilizing one or multiple methods to try to cut that error rate.
60% doesn't surprise me a bit in that.
No.
Yeah.
So we can use the protocol. That's our first tool. But we can also use a product called Certidose. So you would open it, and you have syringe holders for epi, lidocaine, and also atropine. You have this fancy-dancy tape that also resembles that color ribbon.
Color.
I'll call it the color ribbon.
Pediatric color-coded weight-based dosing
chart. Yes. So you would measure the child and find out that you're in the yellow section.
I love how he'll plug Certidose 40 times, but he won't say Broslo, right? he's gonna dance around it, right?
I've not said it yet. I'm thinking about it. I'm literally all that word is like billboarded right now. Do not say it.
But dance around this 10 minutes.
One of the things when we saw this demo that was really cool is you can't with this tape measure from the wrong side.
End, yes.
Correct.
So with the traditional Broslo tape, you can measure from the wrong side, and somebody who isn't
can grab the wrong pouch.
Yeah. Oh, has that happened?
That has happened.
How about that?
That has.
60% of the time.
60% of the time, all the time.
Works the time.
Every time.
But yeah, so with that tape, whichever side of the child you measure from, you're gonna get the same answer.
Yeah.
Short
And the
story.
correct answer.
Yes.
So we had a squad measure from the wrong end, which computed to one of the
Larger.
larger colors. And
Pulled a 6.5 ET tube on an infant.
correct. When they got
Oh,
to the-
really?
oh really? Oh really? Got the tube. Innovate. They're like, this barely fit. I don't understand why. So they get to the ER. This tube is out. You know, and they're bagging, and the ER's like,
They're bagging over here.
what did you guys do?
Bagging with the feet.
And they're like, we innovated them. And they're like, okay. They're like, what color were they on the Broslow?
Yeah.
There you go. Broslow. Well, they were this. And they're like, no. They measure. And,
They were like,
and then they saw him like turn it. And they did it. And they're like, and they're like, well, I mean, your ET tube's good. It's just literally the entire size of the opening. So we're going to switch it. But they were 100% in the trach. There was no room for.
We're gonna put the correct
no
size.
leak.
We're
No,
gonna
there
put
was
the
no
correct
leak.
size ET tube down
Yeah.
your ET tube, and
Yeah.
then just innovate through it. Yes.
But the initial look of the physician when it was like sticking out, they came and got me. I might have been happened to be at Portage that day, and I just need you to look at something. I'm like, wow, that bag is like out. I'm like, yeah, I had the same reaction. You kind of did the like turn the head thing, like how this
Like
worked.
my
but yeah.
dog, cock his head.
Yep.
Oh.
All right, Certidose. Sorry, in a nutshell. So you have these sleeves. So if I wanted to give my pediatric patient epinephrine, which would be my first line drug, whether I have a shockable rhythm or a non-shockable rhythm, I would assemble 1 milligram and 10 mLs
Good point.
of epinephrine. One of the things that you need to do is you have to put this sticker on the end of the actual medication vial, if you will, and that's going to give you your baseline. Once you have assembled that, this will give you one verification that I grabbed the epi sleeve, because it's going to also correlate with the color that the epinephrine comes in the box. You would remove that. This comes off. Slide that sleeve over, and you will push up to the baseline here that's on the list. That expels the air and primes the epinephrine to be given, just to make it easy so that hopefully everybody can see. Let's say that our child fell into the green on the Certidose. So once you're at the baseline, I would push all the way to the first bar. That's my number one, and that's my first epi push. So there's no pounds to kilograms times 0.01 to try to figure out what type of volume is that now. So reduces error substantially. There are multiple epi ones in the kit, and then you also have lidocaine for your first round of antidysrhythmic if you wanted to take all the math part out of it, essentially, for a safe delivery of the correct dosage to a pediatric patient. So we're very pro this. Derek was involved, and a lot of this whole group was, essentially, when we brought this into the protocol. So great product, and Rainbow supports it to essentially decrease or eliminate pediatric errors or incorrect dosing to a child that's in cardiac arrest. So great tool. If you've not seen it, used it, please look it up. There's a short 2-minute video on Certidose's website. But it really takes the stress out of that, because it's a very stressful situation for a provider. Dealing with a cardiac arrest, treating cardiac arrest, parents, loved ones. It's going to be a very emotional scene, so that can help.
And whatever, this is a solution of
Correct.
many
Yes,
in
yes.
Right.
in this kind of space, right? But I mean, look around, whether it's an app-based thing or I've seen the color-coded tapes that stick on the cot mattress, right? So you can
Yes.
just flip the cot mattress over, and you don't have to get something out. That cognitive offloading is a huge thing, and is error reduction. So, if you're not doing anything in that pediatric space, there's many tools, and some of them don't cost a thing. It's just printing a color-coded thing, or cost very little, I should say. So it's not like this has to be the solution, but there's always somebody coming out with some new way to rearrange this stuff. But the other thing is also pick one and stick with it for your organization.
Correct.
Don't be 27 different ways of people doing the same thing, because then again you're creating a problem that
Yeah, that's just bad. Too many options, and then they're going to be an impasse for which one do I pick to use. Yeah.
The same applies for airway management, right?
Sure.
Everybody wants to have every tool. Well, then you get to that point of how much time are you going to spend deciding which tool is correct? If you're the master of one and you've got one primary backup, then
Great.
You're generally good.
We printed in our organization. We printed all of the pediatric drug dosing charts, laminated them. They're on like a binder ring.
On a ring.
They're in each ped bag.
Yep.
And then we know this is in the drug box. So you have a primary, a secondary.
We went one step further at my last shop. We took these out, and we managed our own boxes. These were in the drug box. This was tethered to that card.
Oh, okay, perfect.
So this and the card were together, so we couldn't inadvertently separate them, right? And but he did something that is worthwhile a discussion. He very intentionally talked about the expression for epinephrine, not in a ratio expression, which is how we were all. Can you talk a little bit about that, because that's certainly for guys that have that are our age, or that haven't come out of school here in the last couple of years. We're all very accustomed to the ratio expression. So what was the impetus for that?
Yeah, so I was so very happy when they got rid of the ratio, because I could not remember which one was which. I remember sitting on pharmacy tests just being like, I really wish this wasn't like that. But essentially we went from epinephrine 1 per 1,000, 10,000, 1 per 10, and got away from that to now milligrams per ml. And so it's a lot easier to remember, but a lot easier to apply.
Yeah.
So if 1 milligram per ml, if I need to give 0.3 for 0.5 for an IM, to mimic an EpiPen, that's really easy math I can start doing,
right.
As opposed to the 1 per 1,000, 1 per 10,000, trying to figure out, okay, what's my actual usable concentration? You're making that that flip in your brain.
It's an additional level of conversion in your brain that you don't need to do.
Yeah. So I have mostly kicked out what the ratios are. So if I get something that's just ratio, I have to look it up at this point, because it's gone. It's milligrams per ml, which is fortunate to come in right at that time.
In all of the pharmacy world, there wasn't too many of them left. There was only like 3 or 4, right?
Yeah.
This was just the one that impacts us, because epinephrine is ubiquitous, right?
Right.
Everybody has it, and
yep.
But and on the protocol side of things, what we started when it was announced that we're going to start depreciating ratio expressions. Really, it was ISMP's.
Probably, I think it was. It
was probably their work. But when the hospital started adopting that on the EMS side of things, at least in our region, what we started to do is we knew, and we still know, that you're just not going to flip that switch off, right? So what we started to do was like 5 years out. It was a very long process. It was 1 to 1,000, and then or it was the milligrams per milliliter, and then in parentheses 1 to 1,000, and then like 2 years later, we grayed out. It was still there, but it was really hard to read.
Yep.
We grayed out the 1 to 1,000 or the 1 to 10,000 to the point where we just kept nibbling it down, and then it wasn't anywhere on the page, but it was in the header, and then we eventually got rid of that. So and in that same time frame, just observationally, I've watched the packaging change, where it was basically doing this. Everybody had the same idea. We didn't even talk about it. Is I'd pull it out, and it would say 1 milligram per milliliter, parentheses 1 to 1,000 underneath. I'm like, and I don't know if it still is now, but certainly on the pre-fills, it was 1 to 10,000. Last one I looked at, it was just 0.1 milligrams per milliliter, right? It was like, all right, it's over with. It's time to know the new thing. But that adds consistency, because everything else is in milligrams or micrograms per milliliter. Right. That's why would you do an extra thing, right?
Right. And especially with something like epinephrine. So I don't think. Well, we do have two different versions of epi in here.
Mm-hmm.
It just they happen to be one's a syringe and the other is a vial. But go to our hospital crash carts, for example. We have 3 different versions of epinephrine in that crash cart.
10 mics.
Yep.
Yeah.
So it really, really matters that it's consistent and specific.
You give them pre-filled push dose epis.
Mm-hmm.
Yeah, you're so nice. It'd be awesome. No, we don't need another. I think they have a very extravagantly short shelf life.
Yeah.
Yeah. Okay. I knew there was a reason that we didn't adopt that, but the 100% that still applies to EMS. We just are asking our providers to make that concentration.
Right.
We're asking them to make 1 to 100,000, or or 10 mics per or 0.01 milligrams per milliliter.
Mm-hmm.
I'm glad you said that the way you said that, because I did want to hit that ratio expression thing. It's not going away, folks.
But it does make more sense. The ratios, even to me, I was trained in the interim phase. I had to learn
kind
both,
of both, yeah.
But it's much more convenient now, to be honest with you. I think the only other thing we didn't touch on, which is kind of goes with peds, is pregnancy. So we have another special population, right?
I even know the guy that wrote that in there. That he wanted to talk about that and he missed it.
Individuals that there are a set of drugs and medications that they shouldn't get because it can be detrimental to
Fetal
them
harm,
or the child. So, do you want to talk about those?
Let's talk about those meds and the pregnancy classes, right?
Well, and that's been a tricky part, is that we have steered away from pregnancy classes. So where we used to have the, A through D plus X, category X, do not give, very bad, down to category A, where it's probably safe. They've really taken that away and have gone more towards, here's the information we have, you make your own decision, which is okay, because now I can see, okay, this was an animal study, but has been used for years and is probably fine, but this one study was a little shaky, versus, oh, this happened and it was really bad. We're not going to do that anymore. So it's become, my opinion, a little bit more challenging in this environment, because it's not always clear what this data or what this trial set would have been in the old method.
In the old method.
Yeah, some of it's still there, but especially the new drugs coming out, they don't label them that way anymore. So,
and I'm glad you framed it that way, because I wanted to talk about the protocol side of that things, because it's become that much more difficult for us, because we haven't. Everybody knows it, and we have to give definitive guidance to a pre-hospital provider. I can't say, here's a body of evidence that may or may,
right.
That's it has to be a succinct thing. So to kind of try to still have the doctors tell me where to place that information in the protocol and call it something, so they'd be like, oh, that's that's a category X. I'm absolutely not doing that. There needs to be those definitive lines. It can't be provider gestalt on is this appropriate or is it not, for our purposes. So I've had a real hard time, and well, I know you can search it. You can search the same thing 3 different ways and get 4 different answers, and you're like, well, this is not helpful.
Right. Well, and that goes down to, well, how bad are the symptoms we're trying to treat?
Correct.
Because if we have something that is potentially detrimental, and there was an animal study that showed some concern, I'm probably more likely to say, let's go ahead and give that a shot, versus mild symptoms, uncomfortable but still okay. Well, now that animal and that's the reason we went to this, right?
Yeah.
Is to make that clinical decision based on all the information, as opposed to saying, well, it's category C, good luck, and that's
the perfect example is is amiodarone, right? And maternal arrest, right? 100% chance kid dies if mom dies, right? So, I mean, ACLS is clear on that. They're like,
Yeah.
everybody dies if you do nothing.
Correct.
However, would that be appropriate for perfusing VTAC in, in a mother or an SVT or something like that, or an AFib or other rhythm or rate control? No, that would not be, right? But then that's where that stuff starts getting real tricky. You were to say something.
I was going to say that a lot of the things too is a lot of the drugs are going to be like prolonged exposure, right? So it's not
Right.
There's a lot of times that we're saying, a one-time dose of a medication is a much lower risk than taking that medication every day, so on and so forth. Great example for that's going to be hyperemesis gravidum, right? Pregnant vomiting. We have pharmacological things that we will give the patient that if they work, great. If not, Zofran can cause developmental issues in the fetus. A one-time dose of Zofran, you can't say it's not.
It's
very
unlikely, yeah.
Extremely unlikely.
Yeah.
I'm going to say, hey, but I think you need this. I think that this is safe. I'm not going to prescribe you Zofran.
Right.
I'm going to say, we'll give you Zofran here. We'll get you under control. I want you to call your OB-GYN tomorrow, today, whatever. Talk to them about how we're going to next manage this. So understanding that, and we do that all the time, even in like the not pregnant patients. All those patients that are on like blood thinners or antiplatelet medications, I can't take NSAIDs. I'm going to give you Toradol once,
right?
And it's going to be okay.
Right.
We don't want you to take these every
Can't
day
be
because of this
You
interaction.
can't be gobbling them,
Exactly.
3 times a day.
But on a rare occasion, we're going to make that educated decision, that clinical decision, that the benefit outweighs the risk in this circumstance.
Yeah. And that should not be a decision that EMS is necessarily making. Either you've either you've pre-authorized it through EMS protocol, or we're making that decision with real-time online medical direction. Yeah.
To kind of like come full circle, and Caleb was one of the ones that wanted to be on this podcast, couldn't, but to talk about like we had situations where people make mistakes and they're scared that they're going to lose their license, and that's not our goal with any of our education or critiques or you making a mistake. It's to identify the issue that happened, why it happened, how can we prevent it in the future, how can I educate you to make you better. My job is here is to make you a better provider, not to take your license.
And I think to that point, from the pharmacy side, we're looking at process. So my internal is if 10 people were in that same situation, how many of them could have made that same error? And obviously it's a guess, you don't know. But if it is, hey, this person had really dangerous practice, they never checked the thing, they just blindly reached in the box and pulled, and that's a pattern of behavior that we want to identify, intervene on, and we need to have some care and be vigilant toward making sure that we are looking, we're checking, we're using those cross checks. That's still not enough, right? And so we talk about the Swiss cheese model, where each layer of safety that we put in is not perfect. There's holes, and when a error gets all the way to the patient, it's probably crossed through multiple holes.
Yeah.
The big thing is, don't remove layers of the cheese unnecessarily. So you sometimes see I've never made a mistake. It doesn't happen to me. I'm too good. You're starting to remove error. The thought that you even could make a mistake. You're probably going to skip the cross checks. You're going to skip the double checks. You're gonna do those things. So, but as these errors come up, if our Zofran, oxytocin issue, you look at that, you're like, hey, a lot of people can make that error in the right.
Sure.
Let's fix that process. Let's go after that instead of going after the individual, because if we fire that person, we get rid of their license. The next one up, you run the same risk, and
there'd be no providers left.
Exactly.
I mean,
exactly.
Who at this table has not made a mistake? I mean, come on.
Right.
Today?
Yeah.
Well, and I think
Waking up.
to both of your points, it starts with you being forthcoming.
Yep.
And that's usually the first step in the right direction.
Yeah.
Is like what I would say is being forthcoming, going to the medical director or the ER physician at that point in time. If we're speaking about EMS, I made an error, and just boom, start there, because that's usually the biggest first step in the right direction, and that's what helps.
I just had a light bulb go off, just like you did earlier. We don't, and something we should probably look at with EMR of getting that error on the iPad of you're giving a medication. There's a contraindication for that. You guys in the pre-hospital space are operating with less layers of Swiss cheese. Mm-hmm. You don't have that warning with the interactive system. You're not. We have nurses, and the nurses hate it, right? I'm sure your wife hates it. This whole scanning megs and bagging stuff down. They don't like to do it because it's an extra step. Yeah. It's there for a reason.
Time consuming.
It is, but it's a huge safety step, right?
Right.
To make sure you're giving the right medication to the right patient at the right time without causing harm.
Yeah. Right. Yeah. And not that anyone wants to rely on that, but every month in our med safety meetings, we find because part of the technology is how many things were scanned that weren't correct. And some of those things that get caught are shocking. It's like, how did that get through? And it's like, but next month we're going to have one that's just as shocking.
Wow.
That without using that technology, or if that technology is overridden, it's getting through. And then you get smart pumps and all that. These things that don't exist really in that pre-hospital space yet. Yeah, so you're already, you're at a disadvantage than what we have in the hospital space.
Well, even smart pumps, I had an issue where the one pump that was configured incorrectly in the whole emergency department of 22 rooms plus 10 extra bed spaces was in our trauma bay that epinephrine for epidrips was not configured correctly in.
Wow.
I identified that in a cardiac arrest case because I wanted to go up and it wouldn't let me.
Wow.
So, I mean, we know that errors and mistakes happen, but that's why we report those errors and identify what the root cause was. And, we're going to fix this for next time. How can we make the process better? So that way an error like this or the same error shouldn't happen again.
All right. Well,
I guess all this information will be available online at prehospitalparadigm.com.
Yep. We'll put links to Certidose, and I don't know, maybe we'll even spell out contents of our box and some others, UH specific things if the rest of the world wants to have a look.
Yeah, and if you have any questions, you can send us a question on YouTube, Facebook, or even on our website. I think that especially this podcast with talking about the drug box and medication and these processes really kind of lends itself that we want to hear the questions from you of what questions you have, because your experience has been different than ours.
Absolutely.
And probably run across things that we didn't even think about. We want to make our process better.
And likewise, if you would like, and you're UH Medical Control, that's the important part. If you're UH Medical Control, you'd like us to come and maybe bring Derek with us and do this live at your station, well,
for some CEs,
for some CEs in person, again, prehospitalparadigm.com, and host the podcast.
Yep, and we've got free online Ohio CE available for this podcast and all the podcasts before it, also available. So sign up for that.
All right, everybody, take care.
Thanks.